I'm Kuule Yusuf. I'm a mental health worker working currently with the Bwindi Community Hospital. I started my journey in mental health work in the year 2001 at ETC's hospital. And since then, I've seen this service grow. Currently, as we talk, I think by the end of the last financial year, we are estimating to have served about 20,000 patients. Before we started this work, we had a challenge that mental health work was being provided at regional centers. That included Kabale, Marara, and Fort Portal regional referral hospitals. So I thought of an approach where we could treat people from near their homes. And this is what we called a community mental health service, which has three features. One is being community oriented. For example, here at Bwindi Community Hospital, our patients are served in such a way that 80% are served in the community and 20% are served here in the hospital. That's one feature that the service has. The second one is integration. We have tried to make sure that this service is integrated into the existing services. And I want to thank our non-specialized health workers who have worked with us. We normally give them basic skills in providing mental health care using the World Health Organization Mental Health Gap Action Program, commonly known as MHGAP. And then we work together with them to make sure we serve these patients in the community and in the hospital. The other good feature we found very helpful is the collaboration. We do collaborate with other stakeholders, including local governments, religious institutions, and other stakeholders, those who partner with us in providing mental health care. This service with these features has had an impact. As I've already mentioned, we've seen a large number of patients being served. 20,000 is not a simple number. That is not going to the regions to overcrowd the wards there. The other impact we've had is that it is cheap. We've discovered that it's a cheap approach because we don't have many resources that we are using here. We are using the existing resources mainly and with a few other resources. So it becomes cheap for the hospitals and also for the patients or clients. We've realized that the length of stay is very short. Like for instance, here at Bwindi Community Hospital, our length of stay is only 6 days. I've worked at the national referral hospitals and the regional referral hospitals. Patients do normally stay for weeks, but for us, the average length of stay is only 6 days. There's also reduced stigma because we've seen these patients are managed on general wards and general OPD. Like for example, here at Bwindi, you have just a small room where we conduct the clinics from. But those on the wards are admitted on the general wards. There are other contributions that I've made as an individual in this work since I started. One of them is research. Since I began, we've published 6 papers, and out of those 6, 50%, I'm the first author. The other contribution is grant writing. Of course, to look for money to make sure mental health work goes on. The other contribution is capacity building. The MHGAP activities are not only here in Chizi and Bwindi, but we've conducted them in in Roharo Mission Hospital. We've also conducted them in Kagando. We've connected them with other organizations, including Mental Health Uganda. Of course, I can't take this for granted. There are some qualities that I think might have made me enable me to do this work. One is the love for the patients, especially the mentally sick, and having empathy for them. The other one is good relations with team members. The other one is collaboration with the stakeholders. These are the ones who support us and give us resources. The other one is using data as evidence to work, and also lobbying for resources. This cannot go without challenges. The first one is poor access and poor roads. This poses a very big challenge. We normally use motorcycles, and we find it very hard for us to travel, especially when weather is not good. It would be better to have, say, vehicles or a vehicle to survive very well in this remote place. Limited funding and staffing, of course, we can't say we are comfortable. We need more of the specialized staff, especially mental health workers. Then also treating of the acutely sick patients. Because we manage most of our patients on general wards, you discover that when you get an acutely sick patient, it becomes hard for you to manage. So of course we need acute treatment rooms in these areas or centers where we have these services. So it is from here that I would like to say that it is possible that we can provide services to very many people using this approach, especially if resources are availed. And to me as an individual, I see that if Uganda takes up this approach, we shall see very many people treated for mental health challenges. And then we see that the health of our population is good. Thank you very much.